Okay, this is Dr. Kish Wasan. He lives here, sort of. Lives and works in Vancouver. Works with at UBC, and I can't even begin to give you his CV because I can't pronounce half the words and it's too long. But he's a pretty distinguished guy, and he's doing this research project, which some of us have heard twice, and it's quite fascinating. And Kish has an amazing ability to take something that, to me, is like hearing somebody speak Sanskrit translated into 3 other languages, and I don't know what they're talking about, and make it easy enough to understand. So I'll just leave it at that and give you Kish.
Well, Murray, thank you very much. I guess I am an honorary member of the Saskatoon Prostate Support Group, and just a little bit about myself and my background, so you know who I am. Originally my parents are from India, but came to Canada in the late 1950s. But I was born and raised in Kingston, Ontario, and my parents were professors at Queen's, and I did my early childhood in Kingston. And actually, one of the reasons why we live in Saskatoon is because I had an amazing childhood under the globe of Queen's University, so it was a great place to grow up as a kid. And I find Saskatoon in a lot of ways is a great family place, and it's been a wonderful place to raise our 4 children. Plus, it's a great faith-based community. Some of you who are in the audience know that I spend a lot of time at church, and it's been really great in that respect. I did my undergraduate degree in pharmacy at the University of Texas in Austin. I decided to run away from home, and I was a big Dallas Cowboys fan, but don't tell anybody that. And after my pharmacy degree, I worked as a clinical pharmacist at Presbyterian Hospital in Dallas. But I was what they called a decentralized pharmacist because I worked on the floor, and I ended up working with oncology patients and with physicians and oncologists. And actually, that's where my love for cancer came. Following that, I ended up going back to graduate school and doctoral work at MD Anderson Cancer Center in Houston, and did my doctoral work at MD Anderson and finished my degree there. And okay, yep, right, thank you. And I like to walk, so I'll have to stand still. And then following that, after a postdoc, I was actually recruited to UBC. And I was at UBC I've been in UBC at 2 stints. So I was there for 20 years, worked my way all the way up to Associate Dean of Research. And then I was actually recruited here. I became the Dean of the Pharmacy School here at the University of Saskatchewan and did a term doing that. And then I got out. I got really lucky. I finished my term as Dean just as COVID hit. So I didn't have to deal with COVID as a faculty member. And I was going to retire, guys, and at that point I actually got called back to UBC, not only for some global health work I've been doing for the last 20 years, but for the research that I'm going to share with you today at the Vancouver Prostate Center with my colleague, Dr. Mike Cox. So Mike and I have been working together for a very long time. We actually started this collaboration during my first time at UBC, where we worked on the role of cholesterol and cholesterol metabolism in castration-resistant prostate cancer, and that's what I've spoken about with Murray and with you all several times. So today I'm probably going to talk a little bit about that only at the very end, because I've got some new exciting work that I want to share with you and what we've progressed over the last number of years. So I've been working at the Vancouver Prostate Center, and I've got an appointment in urological sciences in the Faculty of Medicine at UBC. But this all occurred during COVID. So we're in Saskatoon, and this type of thing happened in COVID. I was able to kind of work remotely from Saskatoon during those first few years. But once COVID broke and people were going back to work, I wasn't exactly sure what we wanted to do. But the university said, Kish, why don't you just come in and out when you need to? And that's what I do. And that's why I made the joke that me and WestJet have a kind of an interesting relationship, because I go to Vancouver a lot. But my family's here. My wife is actually a professor at the pharmacy school at USask. My son just graduated with an agriculture degree at USask and is actually now in Alberta in graduate school. And my daughter finished high school at St. Joe's and is actually now in Toronto. And I've got 2 younger kids. I'm an old dad, very old dad, who are hopefully graduating, and we'll get rid of them. And then I don't know what I'm going to do at that point. But we've been really working on castration-resistant prostate cancer really for the last number of years. And First of all, I want to acknowledge it really takes a village of people and a team to do the kind of research and the kinds of things that we do. And the great thing about the Vancouver Prostate Center, which I think you will all appreciate, it's not just fundamental research. It is taking fundamental research and translating it into the clinic. So we work with physicians, we work with pharmacists, we work with basic scientists, we work with other healthcare professionals, public health people, and we have graduate students, medical students, undergraduate students that work as a team to solve the problems from a practical perspective. It's great to do really cool research in science, but if we're not going to be able to translate it to better healthcare, better strategies to treat prostate cancer and to try to mitigate it, what's the point? And so that's the one thing I really love about working at the Vancouver Prostate Center, is that it's really an intermix of folks from all different things, and we try to take the basic science that we're doing and translate it to the next new therapies in the clinic, or understand what's happening with the progression of the disease so we can come up with better strategies to help all of you mitigate the disease, or if you're in the middle of the disease, how we can make it better for you. So I think that's really important. And this is just part of the team that we have there. We have a number of physicians, postdocs, graduate students. The team's actually bigger than this. And we actually meet on Tuesdays. We have these long lab meetings on Tuesdays. Just had the lab meeting the other day where we have updates. And we've been very fortunate that we received two, and actually you guys were my lucky charm, because we had applied for the grant just the last time I was here, and we didn't know if we were going to get funded. But we got subsequently 2 brand new CIHR grants, Canadian Institutes of Health Research grants. So that's our federal funding to help us continue to do the work that I'm going to share with you today till 2028. And CIHR is funded by the taxpayers of Canada. So it's actually your money, your taxes, all right, that are helping support the work that we're doing. So we really have a mission and a mandate to serve you, because the money we're using really comes from your taxpayers' dollars, my taxpayers' dollars, all of our taxpayers' dollars. We also have great support from the Prostate Cancer Foundation of BC at the time, now it's of Canada, and also Prostate Cancer Canada had been supporting some of our early work that ultimately gave us the preliminary data, so we have this federal funding. And the one last thing I'm going to tell you, and as we're sharing, we've been able to expand, and this is something, Murray, you may not realize, we've been able to expand our collaborations. And we have a wonderful collaboration with colleagues at Laval University who have developed some novel molecules to be able to treat castration-resistant prostate cancer. And I gave a talk out there about 2 years ago. I love Quebec City, right? If you can't go to Europe, the place to go is Quebec City, right? It's just a gorgeous place. But they have come up with some amazing molecules, and we've now formed a major collaboration with them and funding with them from the Canadian Institutes of Health Research to try to see if we can move some of their stuff forward. They're chemists. And what do chemists know? They make wild drugs that are toxic, and we've gone ahead and said, okay, we're going to help you here, make it so that it can be translated. So what I want to do is kind of give you the big picture. Many of you should know this. I always say to folks when I'm talking is that if you're a patient or a person that's afflicted with the disease, you probably know more about the disease and everything that you're facing more than we do as scientists and clinicians, because you're living with the disease. You're living with the day-to-day life of it. You're always probably reading about what is the best therapies, what's the latest and greatest thing that you need to use, and you're feeling it. Because you've either had the disease, or you've had a surgery, or you're on a therapeutic, or you're trying to mitigate where you're at. So you understand it better than us from the perspective that it is your life. It is an emotional part of your life, and we get that. So what I'm going to share with you is probably some of the stuff you should already know, but where we are in the big picture of things, and then how our research is going to help address the limitations. Because what has happened is we have made huge advancements in prostate cancer research. We've made new advancements in therapeutics and in strategies and treatment. But god darn it, guys, every time we seem that we've gotten somewhere with the disease, something new happens, and we have to go and try to address that. So and for instance, we thought prostate cancer was actually very simple to deal with. That it was because of an overabundance of androgens, of testosterone, and that if we shut that down, we were going to be able to prevent prostate cancer from growing or spreading or leading to bone metastases and so on. So the early therapies were that, or the strategy of having surgery following by radiation, that if we had negated it at the source, life would be great. But that's not what happened. As soon as we thought we had nipped it in the bud, this whole idea of castration-resistant prostate cancer, this idea that the cancer itself can grow back and generate its own androgens, that it didn't have to come from an external source, threw us all for a loop, threw the whole community into a loop, and that has led to the big issues of the day, which is how do we negate what we now call CRPC, castration-resistant prostate cancer. It isn't now as simple as knocking out the external source of the androgen. How do we get these bloody cancer cells that are now themselves creating their own androgens, from an internal source, and I'll explain to you in a little bit what we think that internal source is and how we're going to deal with it. How do we deal with that? How do we stop the progression? How do we get therapeutics to you and strategies to you where they actually mitigate the prostate cancer, but the theories of the therapies themselves don't make you even more sick, right? I mean, how do you deal with that? How do you deal it as a lifestyle for the rest of your life? And so that's where we're trying to focus, and we've got some new therapies to talk about. So as you know, really there's been 5 approaches from the beginning of time. All right, there's hormone therapy, there's chemotherapy, there's immunotherapy, there's radiation, there's surgery, or there's doing nothing at all. Okay. So why I show you this graph and why I really like this figure is because it really gives you the timeline of what has happened in prostate cancer and the clinical trials and all the different medications that have come up over the last really 20 to 25 years. I can't believe that we're in 2025. I'm thinking that we should be the Jetsons and flying around in planes and stuff, but obviously. Though I have to tell you though, if you remember watching those old Star Treks from the 1960s, Gene Roddenberry was a brilliant man. I mean, if you look at the communicator that Kirk has, our cell phone blows that out of the water now, right? I mean, but really, this all started in the early 2000s, and it's really been now a quarter of a century of the kind of research that we've been doing. So on the far left-hand side of this graph, is there a laser pointer? Oh, is this thing laser point?
There is. I don't know how it works.
Yeah. Anyway, up here, primary therapy. You get diagnosed with prostate cancer. What do we do? The 2 strategies have been radical prostatectomy, removing that prostate. The other is treating it with radiation therapy. And what we're doing with radiation therapy, so you understand, that radiation destroys the genetic code in a cancer cell. So the reason why cancer cells are cancerous is that we have normal cells, right, that are very well regulated. They're very, very well organized. All right, when you go from the birth of a cell to its progression in life to its death, it's very well organized. Every cell in your body, no matter in what tissue, is like that. But cancer cells grow out of control. All right, there's no regulation at all. All right, it's kind of like what's going to happen next week with the Trump administration, right? All right, it just grows way. I told my wife I wouldn't be political. I mean, it grows way out of control, right? And it mutates and grows out of control, and the growth rates are different. And there's no checks and balances. So what radiation does, it goes and kills the genetic code in that cancer cell to shut it down. So between removing the prostate, which is a very serious surgery, as many of you in this room have faced, okay, and you have to have a really good surgeon to get not only all the prostate but the seminal vessels around it, so you don't have any growth or spreading. And then of course there's the damage, surgery. You're damaging the tissue. So if you don't have a skilled surgeon, you can have non-specific tissues that are being damaged, and that's why you have bleeding after the surgery, and you have pain over a period of time because all those tissues are trying to heal. So that's a very radical thing to do, to just remove the prostate. But to make matters worse, we're giving radiation therapy on top of that, and we have to make it focused because that radiation is killing the genetic code in the cancer cell. But if you don't focus it on just that cancer cell, guys, you know what happens, right? is that it starts killing normal cells around it because it's non-specific. It just kills the genetic code. So this is a very dramatic approach. Now we thought in the early 2000s that when this happened and we had salvage therapy, you would see a decrease in the tumor volume and the activity. And we did. But then it started to grow back up. And we didn't know why. And at that point, we called it androgen-resistant prostate cancer. We first thought that there was something else going on, that it really had nothing to do with testosterone or androgens. And the cancer cell was saying something, it was doing something else. And so that's when this whole first line of hormonal therapy and anti-cancer and anti-cancer agents like docetaxel, and you can see a number of different drugs, and I won't go through all this. But the idea was that, okay, there's a second line of therapy, that maybe if we knock down the hormones that are stimulating this prostate cancer from an external source, and then also hit it with anti-cancer drugs, we'd get rid of it. And they did. But then again, it started to grow again. So then we started to see that maybe the androgen receptor itself, all right, that protein that's on the prostate cancer cells that brings the testosterone in from the outside, that was the culprit. And so you can see in this table here, look at all the drugs that were developed between 2004 all the way to 2022 to try to inhibit that androgen protein so that it couldn't take in the androgens from the outside and bring it into the cell so the cell would grow out of control. All right? And that seemed to work for a period of time. But then the cancer came back again. What the hell's going on? All right? So we hit it with chemotherapy. And then it went down, but then we started to have this real problem, which was, it wasn't that these cells were androgen resistant, or that it was androgen resistant prostate cancer. No, androgens were always involved. But now the cancer cells said, we're going to fool you. We're going to make our own androgens internally, inside the cell. And the question was why and how? And it turns out, where do androgens come from? They come from cholesterol. Cholesterol is your fundamental building block for so many things. We have cholesterol on the membranes of cells. We have cholesterol is used for all sorts of processes in healthy human tissues and cells. You know how you look at cardiovascular disease and you say, well, having too much cholesterol is bad for you. Having too little cholesterol is also bad for you. You need to have a healthy balance of cholesterol. Too much leads to atherosclerotic plaques and cardiovascular disease and all the issues there. Too little means you're not going to be healthy, right? Some people are saying, well, Murray, first thing he hadn't seen me in a little while, so you should lost some weight. And the first thing he said to me is, are you sick? I am sick mentally, but that's a different thing. But again, eating food and being properly eating is very, very important. You have to have a healthy balance. So cholesterol is a fundamental molecule that we need in all sorts of living tissues and living cells. Well, cancer cells also love cholesterol, okay? In prostate and breast cancer and pancreatic cancer, they use it because it's a fundamental building block that they can use so they can grow out of control. But in the case of prostate cancer, it turns out that they use proteins that we discovered. We discovered a couple of these proteins that will bring in the cholesterol from the outside, and it gets converted from cholesterol to testosterone inside the cell, and then your prostate cancer starts to grow back up again. And that is called castration-resistant prostate cancer. So we thought, okay, what are we going to do to deal with this? How are we going to deal with this CRPC? And the numbers are staggering. More than 25% of men now are getting CRPC. More than 20% die more from CRPC than from regular prostate cancer. Okay? Many of them, and I'll show you in a minute, it converts into bone metastases. There's an old saying, you don't die of prostate cancer, you die with prostate cancer. And the reason why is because it leads to all these other issues. So now, the cancer said to us, we're going to fool you, man. It's not about just having an external androgen that comes in. And even if you knock it out by doing surgery, all right, and removing the external source of androgens, We're going to create our own. So now we have to come up with a strategy to deal with those cancer cells that are creating their own androgens. And one of the ways is through inhibition of cholesterol. We got to make sure that cancer cell cannot get that cholesterol, so it cannot be converted into the androgens so that that cancer can grow. Okay? All right. This vicious cycle between
Thanks, Kish.
this is this. You're just going to have me talking and then this goofy side view of you can see I like to lecture in the classroom, and the students are half asleep and ordering pizza, and so I have to walk around the room and make sure that they don't. I mean, they did order me a slice once, which was pretty good. So this vicious relationship between prostate cancer and bone metastases is extremely important. We've got to find a way to make sure it doesn't get to this stage for you guys. We've got to make sure of that. Because once that prostate cancer starts to hit the bone, and then it starts to spread and metastasize and spread out, we're in a different ballgame. But the best way to deal with it is, number one, understand it, and number two, block it, prevent it. And what I'm showing you in this very complex slide is that what is basically happening here is these prostate cancer cells, all right, are interacting with different types of cells that are in your bone. And when they interact, that's when they start to infiltrate within this bone, and basically they take over the bone. Again, using a Star Trek analogy, this is the Borg, all right? I mean, a resistance is futile. So and then once it gets into here, we're in real trouble, because it starts to spread. So we need to find a way to prevent this from happening. And that's the other strategy we have to look at. It's number one, knock out that building block in the cancer cell, so therefore you don't have prostate cancer, cholesterol. And number two, deal with how this migration of prostate cancer cells interact with the bone, so that this mature bone doesn't get taken over by these prostate cancer cells and degrade that bone. So now you got bone degradation as well as the spreading of the prostate cancer cells. And that's really quite critical. Okay. Is this thing?
Yeah, you're selecting things.
Yeah. Okay, let's go back. But we're going to use what the cell does to help us beat out the cell. Sounds like it's a fight, right? And I'm Mike Tyson, all right? You know the saying from Mike Tyson, right? You know, you got a game plan until you get first punched in the face, all right? Then your game plan's thrown out of the window. It's the same way here, is that it turns out prostate cancer cells, we all use PSA, as you all know, blood, to measure if you have an issue with potentially having prostate cancer, because there's this prostate-specific antigen that was released into your bloodstream, okay? And that gives you a gauge of where you are in your prostate cancer. All of you get a PSA number, all of you get a Gleason score. But what we learned is that there is a thing called prostate-specific membrane antigen, PSMA. And what it does is it's highly expressed on the surface of prostate cancer cells. Now, it's also expressed in other cells as well, but not to the same level as prostate cancer cells. Now, we could use this to our advantage to help develop therapeutics and diagnostics to deal with it. So, from a diagnostic perspective, PSMA can be used to evaluate the condition of prostate cancer. We can radiolabel with PSMA targeting probes, and we can see where in the body is the prostate cancer, and is it spreading or localized, and so on. But the other is we can actually therapeutics. We can do what we call a drug-specific targeting approach. We can actually put drugs on PSMA probes that will actually go specifically to that prostate-specific membrane antigen and release the drug or radiation to hit just that cancer cell and kill it. So what we're doing is we're using what we call PSMA targeting to be able to be, it's smart targeting, it's smart drug targeting. You know, one of the biggest problems I teach the students about drugs, the reason why drugs have side effects, all right, and it really comes down to a benefit-risk ratio, is how much of the drug goes to the site of the disease, but how much of the drug goes to the non-disease site. And the percentage that goes to the non-disease site, that's what causes toxicity, right? That's your side effects. So what we're trying to do is say, no, we got to find a way to make sure that almost all the drug just goes to the disease site and very little goes to the non-disease site so that it is very effective with low toxicity, right? Because as many of you do know from all your therapeutics and everything that you take, sometimes it's the toxicity that kind of ends the day for you, right? You get sick and go, I'm getting sick, it's not worth it, all right? We're using this PSMA approach. The prostate cancer cells that only express that antigen, we're trying to be outsmart it by putting a therapeutic so it targets just that PSMA site. And that is some of the new therapies that are being developed now. And this paper's only 3 or 4 years old, but there's even newer therapies where we've been able to deal with the castration-resistant aspect of the disease because of PSMA. It turns out that this prostate-specific membrane antigen does express even in cancer cells that are resistant, this castration-resistant prostate cancer cell, not just the normal one. And this, we were dead in the water once we went from here to here. We had to find a strategy to deal with castration-resistant prostate cancer. So number one was the cholesterol story, but number two is this PSMA story. And that's some of the work that we're doing in our lab now. So PSMA theranostics is really kind of a cool approach. What theranostics means is that we're targeting both the diagnostic and the therapeutic drug to the site. And what I'm showing you here is, it's a very busy slide, but I think I sent them to everybody already, so you can look at them and drink your coffee when you have a chance or whatever. Is you see where it's all red up? That's showing where we can target the drug and where we can target this PMSA approach. But we're doing two things at once, guys. We're able to light it up and show you where it is in the animal, and at the same time, we can show you where the drug is going to go. So we can do it not only a diagnostic to show you where the disease is, but we can also do a therapeutic to show where we're going to put the drug or the radiation to kill the disease. And that is what we're showing you here. And you can see the improvement from a diagnostic approach. The red is the improvement versus the control, and you can see there is a dramatic improvement. It's not 100%, and I'm going to tell you why in a minute, but it is very, very effective. So what we're doing here is on the cancer cell itself, all right, where PMSA is expressed. We have all these different strategies to deal with the prostate cancer cells, specifically targeting this PMSA. We can do immunogene radionucleotide. We can do a therapeutic nucleotide. We can do just a cytotoxic drug. We can do photosynthesizers. We're even looking at these microbubbles. They're like little balloons filled with drug in it. All right, and we can attack the drug there. We can use infrared to be able to see where the disease is. So we have now, the great thing that this does is it opens up a whole slew of approaches for us, Barry Murray, open up this whole slew of approaches for us to be able to attack castration-resistant prostate cancer, because we're now getting very specific to this PSMA membrane. All right? But there is a problem. And the problem is, as I said to you earlier, PMSA, even though it's highly expressed in prostate cancer, unfortunately PMSA is also expressed in any androgen tissue that's non-diseased, all right? I mean, saliva glands and other places, adrenal glands. So remember I told you that one of the biggest problems is that when you take a drug, it's not only how much drug gets to the site of action where the disease is, but how much drug is non-specifically going to places you don't want it to go, and that's where you get the toxicity and the side effect. So if you just link your drug to a PMSA targeter and fire it into a patient, we might get 70 or 80% of the drug to that cancer, but we still might get 20% of the drug to non-cancer sites, and that's where your toxicity occurs. One of the things that I think people don't appreciate that we need to do a better job of telling you is that the reason why you get a certain dose of drug for a certain period of time is we're trying to optimize the effect and limit the toxicity, right? But there's a ratio and a balance. We're going to give you enough drug and enough dose so that you get an effect before you see the toxicity. But at some point, we only can give you so much drug, because what happens is the toxicity starts to become a big deal for you. We've got to find a way to make the toxicity so limited that we can give as much drug as we need to knock out that cancer. That's what this is all about. It's a benefit-risk ratio. So how do we deal with that? We're working with chemists at UBC, Dr. David Perrin's lab, who's developed these little short, what they call atomers, DNA atomers, and they're really small, tiny little molecules, which when you put them in the bloodstream, they circulate for a very, very, very long time and only bind when they see diseased PSMA, all right, in a diseased cancer cell. They won't go necessarily to the non-cancer cells. So we're now working these short-stranded DNA RNA binding molecules with drug from our lab. This is some of the work Mike and one of Mike's grad students are doing. I'm involved, I guess. And we're now trying to test that. And we've got some I'm not going to show you the data today because it's still too preliminary, but we've got this preliminary data already. And what we do is we don't do this in just animals. We get actually primary tissue from patients. We luckily have a tissue bank with colleagues at the University of Washington down in Seattle and a great relationship with them. And we actually get real live or tissue samples from patients, either biopsies of patients after they've had surgery or so on. So this is that translational part what I'm telling you about. Okay? And these are just the methods by which we use it and how we inject it. And again, I'm not going to go over that. But there's still weaknesses in even that approach. Remember I told you my collaboration with Laval? Well, 2 years ago, I'm on a Canadian Institute grant with colleagues at Laval to deal with pancreatic cancer. And when I went to give our talk, I was sitting there giving the talk about this work, and back in the room, Dr. Donald Poirier, who's a world-renowned medicinal chemist, said, well, we're doing molecules for prostate cancer as well. Maybe we should start to work together. And this is a seminal paper that they published in Cancer just a few years ago. And what they've done is they developed these aminosteroid derivatives that are very effective in treating androgen-dependent prostate cancer and are as good, if not better, than the gold standard drugs that I mentioned to you at the beginning that's in that list. They're as effective, in fact, in some cases more effective, but they're also less toxic. And these are what these molecules, I didn't want to show you chemistry, but here's what these molecules look like, and they have a whole generation of these molecules. But here's the problem. I said to them, yeah, it's great that it works in androgen-dependent cancer, but I'm really interested in CRPC. I'm really interested in dependent and not dependent, because as I told you all in the beginning, we have a good handle on androgen dependency, all right? But once we get beyond that hormone-sensitive cancer, and all of a sudden now it's this CRPC, we need strategies like the PMSA strategy and the cholesterol strategy to be able to deal with these kinds of cancers. So I said, give us these molecules, we're going to test them in our lab. Here's some of their preliminary data that they showed in their animal models. This is the bottom one is their effect of their compounds, and the top is the growth of the tumor. Now, I'm going to share, there's a lot of data here, but the reason why I'm showing this bottom one is showing the tumor being regressed, and the top being the tumor without any treatment, and then there's all these different treatment groups and control groups in the middle. This is actually very important data from the following perspective. When I read a lot of cancer grants, not just in prostate cancer, but in breast cancer and pancreatic cancer, and all these animal models, people show a decreased rate of growth of the tumor. So they do show that the tumor's growth rate is lower than the control group. But the tumor is still growing, right? It's just growing at a slower rate. No one's showing regression of the tumor or blocking the tumor from actually not growing. And in fact, in real life, that's what you want. You don't want to slow the rate of the tumor growth. Okay, so you live 10 years instead of 5 years, right? You want us to regress that tumor growth. And that's been one of the weaknesses in tumor and cancer research until very recently. So we all started reading grants and started reading what people's work is and said, until you start to suppress the tumor, all right, you really don't have anything special here. You may prolong someone's life, but the tumor's coming back, even with your therapeutic. And that's not even dealing with the side effects of the drug that you might have over a period of time. What's critical about this data, they are suppressing any growth of the tumor over 30 days. That it is not growing. If it's not growing at a slower rate, it's just not growing. This is a very important finding. It blocks tumor growth in these immune-compromised animals. This is a very, very important finding. But it's in an androgen hormone-sensitive model. And I said, but I want to know what happens in a hormone-non-sensitive model. And the men that I see, we're seeing most men now with CRPC. This is a lot of data, but this is a paper that we just published and presented at the Canadian Pharmaceutical Meeting in Edmonton this past June. So this is fresh, brand new data for you. And what I want to show, you can read all the graphs and look at all the different things, but what is important is this table here. If you can't see it, that's why I sent the presentation in advance. What we're showing is both in androgen-dependent and in androgen-independent prostate cancer cell lines, a whole slew of them that come from primary patients, were showing effect. In other words, this molecule also looks like it could be effective in CRPC at non-toxic doses, and it's not only cost-effective, it's safe, it's easy to make, it's cheap, and you can take it orally. This is huge. So now we're moving into animal and in vivo studies with this work to see where we are next. And in fact, Mitali, who is the author on this, is our research associate. Brilliant lady, brilliant. Like I said, it takes a village. Azu, the first author, is a clinician from Japan that came and spent 2 years with us. I could not understand a word of English he said to me, all right? But the great thing about science is a universal language. I couldn't understand what he said to me, but when he sent me the data, I certainly did understand the data. And he was a brilliant clinician scientist. Didn't speak a word of English, and my Japanese sucked, but it was great. You know, one thing I love about research is you work with people from all around the world. It doesn't matter what your background is. All right? So Azu and Mitali did an amazing job. Renee and Don are the two Laval folks, and of course, you know, the goofs at the end, Mike and I, and we didn't do anything, right? But this is a very important finding because now we're showing with his molecules that we can deal with CRPC with something new for you guys to have that is cost-effective, safe. But this story gets even better, and this is the link to cholesterol that I want to tell you in a moment. We need to understand how these drugs work when they get absorbed from the GI tract and come into the bloodstream and get delivered into the cancer cell. You know, I always tell the students, think like a molecule. So you're a drug molecule. Okay, I take you orally, you come into the stomach, into the small intestine. By the way, you never get absorbed. The only thing that you absorb from the stomach into the GI tract is alcohol, okay? Everything else, most drugs, almost all of them get absorbed in the upper GI tract, not in the stomach. The stomach is a digestive organ. A lot of people don't know that, all right, or don't think about that. Most drugs, 90% of drugs get absorbed from the upper GI tract. So when this molecule comes in, it gets absorbed from the upper GI tract. It goes into what we call the portal vein, which lines the GI tract. The portal vein basically flows into the liver. The liver will break down the drug, and the drug will come back out. So you got to find a way all around that. So the drug will come out in the bloodstream, and then from the bloodstream, go to your cancer site, right? But what does it do when it's in the bloodstream? And I think of the bloodstream like the river, like the South Saskatchewan River with all the stuff in it, all right? But in this case, this blood has proteins and it has red blood cells and it has all sorts of stuff in there, all right? Probably grosser than what we see in the South Saskatchewan River at certain times of the year. So when this molecule comes in there, what does it interact with? What does it bind to? What does it glom onto before it gets to the prostate cancer cell? So we look at the plasma protein and lipoprotein fractions of where this drug is going. So remember, if you think of lipoproteins, you think of LDL cholesterol, HDL cholesterol, triglycerides. Plasma proteins are the major proteins in your blood, albumin and alpha-1 glycoprotein. Okay? So what we do is we have an elegant technique where we can actually separate. These are the different lipoproteins that you have in your bloodstream. All right? All implicated, a number of them implicated in cardiovascular disease. You know, LDL cholesterol is the bad guy. HDL cholesterol is the good guy in cardiovascular disease. See how everything interconnects between cardiovascular disease and prostate? You'll see in a moment. We have an elegant technique to separate. I'm actually going to show it to you. This is Azuz's fingers. What we do is we have a density gradient ultracentrifugation technique. In other words, we're able to take the plasma from patients and we're able to separate it by its density into the different lipoprotein and lipoprotein deficient fractions. So we are able to put it in the albumins at the bottom. This one here is LDL. It's a very clear LDL cholesterol. The color, that's the cholesterol. At the top, you probably can't see it, but the reason why I know that that's a fasted, healthy patient is because that's triglyceride, VLDL, and because they haven't eaten and it's fasted, there's no triglyceride or white puffy coat. If you went to McDonald's and then I did this separation of your blood, this would be all white, very, very thick white. That's all the triglycerides from your fatty Big Mac. Okay? So we're able to separate these fractions. And then we have an analytical technique that we had to develop to measure the drug in each of these fractions. Okay? So we developed an assay for that. I won't show you that because it takes an hour to show you the assay, but that's the amount of work that was done. And now I'm showing you the results of that. So what I'm showing you in this box is the following. We have plasma from what we call normal cholesterolemic patients. So these are patients that are healthy males that have very normal cholesterol levels. They're not cardiovascular disease, anything like that. We then have plasma from patients that are slightly hypercholesterolemic. They have a slightly high cholesterol level. Now the reason why that's important is all of you know, many, many men have slightly higher cholesterols when they have prostate cancer. Because what happens is we're trying to generate as much cholesterol as possible so that those prostate cancer cells can get all that cholesterol so they can make their own androgens. That's why many men are on statins, because you want to reduce the cholesterol. So what we wanted to do is get plasma from patients where they're hypercholesterolemic. And then what I show you is the amount of drug that's in each of the different fractions. The lipoprotein deficient fraction, what we call the HDL fraction, LDL, and the triglyceride-rich fraction. There are two really important findings here, huge findings. Number one, it doesn't matter if the patient is normal cholesterolemic or hypercholesterolemic. The vast majority of the drug is either just going into the plasma protein, so it's binding to albumin and alpha-1 glycoprotein, those plasma proteins, or it's going into HDL. It's not going into LDL. It's not going into VLDL. That was a very surprising result because what we thought was, as your cholesterol levels are going up in your blood, your LDL cholesterol is going up, your drug would probably go there. All right? But not this drug. This drug's pretty funky. This drug is going into the high density lipoprotein, 40% of it. And the rest of it's bound to the plasma proteins. Now, why is that important? The reason why that's important is because it turns out in our research, and this links back to Murray, you've heard this part of the talk many times before, in patients that have castration-resistant prostate cancer, we have an increase in the amount of cholesterol in their bloodstream. And a lot of it is HDL cholesterol. And what we learned, and I'll come back to this take-home slide in a minute, what we learned, and I've shown this data before, this is my postdoc, Carlos Leon, who's now working in some big pharma, makes more money than I do. What we showed is in castration prostate cancer, we discovered a protein called SRB1, all right, that is upregulated only in CRPC on the cell, right? Just like PMSA. SRB1 turns out to be the HDL receptor, right? The HDL protein. So what we think is going on is this drug that we discovered with the Laval group is binding to HDL and is being taken up by HDL through this SRB1 receptor. Let me say it again. This drug is going into HDL, is associating with HDL, and it is now being taken up by castration-resistant prostate cancer cells through this SRB1 because it's upregulated. There's more of it in the cell. So that's why we're seeing the effect of potentially this new molecule. In other words, just like the PMSA story where we're using the cancer to our advantage to remove therapeutics, we're using the whole process of how the cells are getting cholesterol so they can make their own androgens. We're using that pathway for us to deliver drugs to kill those cells. And this just shows you an upregulation in prostate cancer cells after they are now castration resistant versus when they weren't. And this is some other data that shows you that. But I think the take-home message here, and this is work that I've shared before, but I'm going to go back and say, what is the take-home message here from all this? The take-home message from this that you all need to take away is the following. Number one, prostate cancer feeds testosterone to grow. All right? I mean, you need testosterone. But 10 to 25%, and actually these numbers are even higher now, all right? Hormonal therapy, eventually the cancer comes back, and that's where this whole CRPC happens. It turns out that you need cholesterol. You need cholesterol in order to make testosterone so that CRPC, cancer-resistant prostate cancer cells, can actually grow. So what we need to do is find a way to starve those people, starve those cells of that cholesterol so they don't have the building block to make the testosterone, so they end up getting that prostate cancer growing and growing out of control. One of the strategies is people are using cholesterol-lowering agents, right, like statins. And there has been indirect evidence in clinical studies, and we have one clinical study that we did that I think I showed you last time, that shows that statins do have some effect on castration-resistant prostate cancer because they inhibit cholesterol, right? But now what I'm saying to you is we have another strategy where we're going to take this drug, this RM581, this aminosteroid derivative, and when we give it to our patients, it's going to go into HDL, and through that HDL protein pathway, that SRB1 pathway, we're going to deliver it into those cancer cells and kill those cancer cells. So we're going to use the fact that these cancer cells have this increase in this protein to help kill those cells. So that's the latest updates from our lab in this area. I think for you, there is hope that we are now got multiple strategies and multiple approaches to be able to treat CRPC. The last thing I'm going to mention, we were debating at the lab meeting on Tuesday if I was going to show you guys this provocative data or not. I'm just going to say it to you because we have to validate the data. We have discovered now that the bone metastases prostate cells are also overexpressing this protein, this SRB1, this HDL protein. And the reason why that's really important is because then we might be able to come up with therapeutics to be able to start targeting that as we get to the beginnings of bone mets. Right now, that's the other black box, is that once you start to get to bone mets, you're in trouble. You're in trouble. And we don't have a strategy yet to deal with it. We have a strategy to deal with the early stages of prostate cancer and hormonal therapy and radiation and surgery. We now have strategies to deal with castration-resistant prostate cancer, the stuff that grows back after we got rid of your prostate and radiated the heck out of you. So 2 out of 3, we're in great shape. We're starting to get there. We're going to make your lives better. But how the heck do we deal with those poor men that now, unfortunately, it's spreading into bone tissue? Because if we can't get it to that bone tissue, we're in deep trouble, right? And you all know that. You know that better than I do. You're all worried about that. I'm worried about that. And that's why this SRB1 discovery, that maybe this SRB1 protein is upregulated in the bone mets, and we have drugs that can target that protein at bone mets to shut it down, that could be a huge discovery in dealing with early stage bone mets. which would be a big, big thing. So with that, I know there's a lot of stuff there, but I hope you got an appreciation of where we're trying to go. It's been an exciting time working in the group, and I'm open to any questions or comments. Thank you very much.
How far do you think this is from human trials?
Which one? The MR 581?
Yeah.
Probably about a year and a half away now. We're not that far.
And then you have to go through, what, 3 phases?
Yeah, so what you do is you do what we call phase. So Murray's asking the question for the video here. Murray's asking the question, how far are we from clinical trials, and what is the pathway for those clinical trials? So I would say we're outside probably 12 to 18 months away. We'll see where we are this time next year. But there are multiple phase trials. There is what we call phase 1. Phase 1 is in healthy humans to show safety at the highest doses we think will work in efficacy. So that's phase 1. Then there's what we call phase 2A. So phase 2A would be all the men in this room. We do a small cohort who have prostate cancer, and we give the therapy at doses that we know are safe, that we determine from phase 1. And then if it's effective there, then we go into what we call a phase 2B, which is a larger cohort. And then if it works in that, then we do those big, huge multi-center site studies with thousands of patients, and that's phase 3, 4.
And that takes
that takes a while, and you need a lot of cash. By then, I'm going to be long retired, or I'll get one of my grad students who's making more money than me in big pharma to pay for it. But that's an excellent question. But we're now making the headway in there. By the way, the therapeutics that you see, all these different drugs, there are tools in the toolkit for the clinician and for you to work with to see what might work for you, what might not work for you. Okay? And so we're just trying to get more tools in the toolkit to deal with your specific situation and where you are. Of course, you all know that the best situation is early diagnosis and early treatment, all right? And depending on where you are along that pathway, that's the way to go. But once you're there, particularly once you've gotten surgery, and I'm now talking to a lot of men that have had the primary surgery, that had radiation therapy, that are in now that stage 2, 3, the diagnosis story, early detection's gone. You've already had the surgery. How do we make sure that it ends there? And that's where the whole CRPC story and the whole bone met story becomes the big picture that we have to deal with and make sure we have tools in the toolbox for you to deal with that. I probably went way too long. Doesn't matter.
Nope, doesn't matter. Questions?
I hope that was understandable. Yes, sir.
Just wondering how well you are passing the information on to our working physicians out there, the oncologists and the urologists. Do you end up having a symposium and getting them together?
Oh, we talk way too much, man. Yeah. The short answer is yes.